Thank you, Ian. Up next, we have Sophia. Sophia, if you can go ahead and unmute yourself, please.
Hi, doctor. Thank you so much. Um, I'm over 15 and I underwent a knee synovectomy because of RA. And I always put knee braces. And recently, my physiotherapist told me that I have tophus. Do you have any advice?
Yeah, so this is a different condition now. You've got rheumatoid arthritis, or RA, as I understand it. A different condition, and one that is normally best managed with medication. And this is where there has been a lot of progress in medicine. I'd be the first one to criticize it, but I've seen it. I've lived through this when I did my training. Most of the patients that had joint replacements, knee replacements, hip replacements, were patients with rheumatoid arthritis. These days, rheumatoid arthritis makes up less than 1% of all the joint replacements that we do, because it's not it's been controlled so well by the newer drugs, disease-modifying anti-rheumatoid drugs. So there are drugs that can manage RA and can help it. Surgery is not so helpful until the sort of end stage. And I can't really give you individual advice. I have to see your x-rays to see how bad the knee is. But sometimes when the knee is very bad with RA, we still end up doing surgery. And sometimes that surgery is even the final surgery, which is knee replacement surgery. But I can't comment really on your individual case, so I'm sorry about that.
Thank you, Ian. And up next we have Michelle. Michelle, if you can go ahead and unmute yourself, please. Hi, Michelle.
Hi. Yeah, thank you. I have a question. I'm wondering if you think that it's possible, with the examination you've done of this issue, that the overuse of surgery is related to the overuse of medical imaging, and particularly the inappropriate use of imaging. I'm from Canada, and we see a lot of that here. I'm a hospital-based project manager. And I've heard the radiologists and the surgeons comment that when there's overuse of imaging, then there is a compulsion on the part of the physician as well as the patient to do something about findings that they otherwise never would have seen that and weren't necessarily problematic.
Absolutely, 100%. Yeah, that's very clear. I write about this in the book, and we've actually got a new book coming out later in the year with a professor of medicine in Melbourne, and that is very clear. It's the over-investigation, over-diagnosis that occurs that leads to surgery. There's some great examples of this, but MRI of the spine is a classic. If you do an MRI of anybody's spine over the age of 30, you will find something. You will definitely find something in like 99.9% of cases. And so what surgeons do is people come in, they go, oh, I got back pain. And they look at the MRI and they go, well, I can see something on your MRI. One of your discs is a bit dehydrated, because discs are made of collagen and cartilage, and they dehydrate over time. Same reason I have wrinkles, and the same reason we get flabby. And so they say, oh, that must be causing your pain, so I'm going to fuse that segment of your spine. It's definitely a cause. MRI of the knee, we've shown correlations where procedures have increased. And in Australia, we published this in the spine, where in around 2000, 2001, MRIs became publicly funded. So you could get an MRI scan and get the government to fund the scan. And back surgery, back fusions took off from that point on. So there's a definite correlation. And there's a great study done in the US years ago now, where they, in primary care, where they took patients who presented with back pain and they randomized them to two things. In one, they got an x-ray of the back, and in the other one, they didn't get an x-ray of the back. And that was it. And after that, they said to the doctors, you do whatever you want. And they found a year later, no difference in the amount of back pain that each group had, but the group that had an x-ray were more likely to have had surgery in the interim. So if you find something, people will want to act on it. Patients will want it acted upon. And I talk about the incentives here. There's a lot of incentives. Surgeons want to do something because people want them to do something, and people want something done, and their relatives are saying, you really need to go to the doctor and get that seen to. You need to get your back pain sorted out. The hospitals want it done. Hospitals get paid to do it. The device manufacturers want it done. Everybody wants it done. Everybody wins out of having procedures done. And unfortunately, it often starts with investigations. If you look at back pain now, many of the international guidelines on how to manage back pain, one of the first rules on how to manage back pain is don't image it. Don't get an x-ray and don't get a scan, because you're just going to find a whole bunch of things that are unrelated to your back pain that are going to end up getting injected or fused.